And without further ado, I would like to introduce our first discussion will be with Robin Murphy. Robin Murphy is the Distinguished Raytheon Professor of Engineering at Texas A&M. She's also a robotics rescue expert and the chair of Robotics for Infectious Diseases. And Robin has been doing a lot of work in understanding the role of robotics in the current COVID crisis. So we're honored to have her starting our symposium. Over to you, Robin.
Well, howdy, everyone. I'm from Texas, and thank you so much for having me here because I don't do healthcare type robots, but COVID is an infectious disease, and that is a disaster in type of that. And we've been trying to capture what actually is going on with it, what the current uses are. So let me just quickly share some slides, and hopefully we're not doing the whole death by PowerPoint. I think one of the first things to look at that we've been keeping up with reports in the press, social media, anything we can find. We found to date about 243 reports. 36 of them describe how robots are being used for what we call clinical care. These are hospital-oriented type of care versus a nursing home or assisted living of the elderly in their home. So if you look at them from the most frequent to less, disinfecting, the point care, the hospital robots that are going around with the UV light, healthcare worker telepresence, that's also incredibly popular. Prescription meal dispensing, taking away some of the scut work there. And you're also seeing a little bit of that as well as taking back the trash. Handling receptionists, robot receptionists, beginning to let them work remotely and not be at the front line of dealing with that. And then also using the same teletechnology to let patients and families socialize. And we've seen one with inventory. So let's go to the next one. Now, here's what I think gets interesting for us as roboticists and working in healthcare. If you use the NASA technical readiness categories, where heritages are essentially robots, technology applications, commercial off the shelf, it's in standard use. Engineering are those that require some tweaks, but it's mostly commercial off the shelf with a modification. And then we have novel, which is the robot is novel, or the function is very different than what the robots have been used before. If you look at this, you see that the big one is heritage, is that your big use of robots is commercial robots that were already there, maybe not as well known, maybe still early in the adoption phase, but already certified, already commercially available. And the same thing with engineering. What you're seeing here is in those cases, you're seeing people take a turtle bot or another type of cart robot that already exists and doing some modification to it, using a universal robot arm, adding a new infector, temperature probe, or pulse ox, something like that. It's only in the new category do you see the novel robots and functions, but they're not really new. These are robots that are prototypes that had already been prototyped and were already showed a partnership with the hospital or the medical group that's doing it. So we're not seeing any new, hey, today I shall pivot and my robot company shall do healthcare from here on out. We're seeing that's not a big surprise, right? As you know, healthcare is an incredibly specialized field, all sorts of user stakeholders, regulatory nuances that a normal, well, I don't know if normal is the right word, an average roboticist would not know about. And then what I think is interesting, now there's out of those 36 reports in the press and social media, 9 of them actually mention gaps, which you think is kind of weird, right? Because we think of us as roboticists and as end users as being able experts to define what the gaps are, what the opportunities are, all of those sorts of things. And instead we're getting people, journalists, patients, people complaining or making points about it. 4 of them actually questioned the role of appropriate autonomy. A lot of the robots that are doing the disinfectant are automated but they don't adapt to the geometry of the room. So basically you just get to the middle of the room and then just go blast out UVC light, and don't worry about the fact that parts are going to be in shadow in there, and a person will just come in and clean it up. Teleoperated robots, very popular, but no surprise to those of us who work with teleoperation. The healthcare workers crash them. They get them stuck under the beds, where the wheels get trapped and things. So they don't have quite the level of autonomy, of that shared autonomy, that we would like. Concerns over health and safety standards. Robots have to be decontaminated, and some are clearly not built that way. Emerging concern, I would change that now from 2 to 3. We've got another evidence that came this morning of where people, robotics is complaining about copycat robots. They're doing a great job of adding things to their existing robots, but they don't have the performance claims. They don't have the reliability. And this causes both problems, they're not the same as the ones who have gone through the years of testing with hospitals. And also they can give everybody a black eye. Poor human-robot interaction. In 2 cases, it explicitly scares or annoys the patients. And one of the cases is the Tommy robot in Italy, which is very professional looking, a humanoid. It's got all the things, and the elderly still didn't like it. And of course, we've got physical human-robot interaction where we have to touch the patient. And the concern is that may be brittle. You get it to work for one patient, but different patients come, as you know, in different shapes and different sizes. So that's on top of all the gaps that we as roboticists and experts in healthcare know about, but there's that. So I thought that was interesting. Back to you, Andra.
Well, that is indeed interesting, because one of the reports that someone's talking to me about is analysts in the robotics industry are putting together a compilation of the ways in which robots are being used as autonomous mobile robots, and they've pinpointed this disinfecting application as a new category that they counted 30 companies in. Mm-hmm. And I'm staggered, because I'm pretty certain that at the start of this COVID crisis there was a maximum of 5 operating.
I was going to say 5. Yeah.
So that's a lot of new companies aiming to insert themselves into the health industry.
Yeah, and that, I think, is a problem, right? Is because, as we know as roboticists, it's actually hard to build a working system, right? And have that reliability. And also, if there's already 5 companies working in that space, what is your distinctive competence that's going to give you any kind of market advantage? Because you're really, on the wave of innovation, you're really coming toward the tail end. Because companies doing disinfecting started back in 2015, both as Ebola and as hospital-acquired infections. So jumping in now, they've got 5-6 year head start on their technology. And what does it do if you get companies that low bid and aren't as good and don't understand what the coverage is and the efficacy is? What does that do to the entire market? Will they poison it for everyone?
Yes, now that is something that we've faced with a number of other robot applications and indeed in the autonomous mobile robot space, for example, there's a lot of education to explain why these robots are different to the older style robots and how significant that difference can be. And I think that's particularly dangerous in more critical use cases, as you pointed out. These are not necessarily robots that meet the health and safety standards that you've talked about. I'm very interested, because my background is also more in the HRI side, with the things that you've pointed out in the gap analysis of poor HRI. And you talked about a particular nuance there that I think is endemic with robotics, which is brittle HRI.
Well, in the brittleness of the physical HRI, I thought was interesting. I mean, of course, we all know how difficult it is to touch and all this. And we're talking about a system that was already being prototyped with all the regulations and all the care. And apparently the first thing everybody who wasn't part of the research program said is that, whoa, how is this going to work outside of the small number of patients that they're trying and demonstrating on? Now, of course, one of the problems with all of these reports, besides the fact that they're press reports, they're not scientific, we're seeing more, some of them are demonstrations, right? They're clearly not built to go into actual use. They're taking advantage of, you know, like in Houston, we have several hospitals as part of the larger medical complex down there. And some of them aren't really busy right now because everything shut down for COVID. So they can start experimenting and they're like, oh, we can try robots here. Let's go do it while we, you know, we don't really have a high capacity. It's not going to interfere with anything. But it's fascinating to see these demonstrations, what people's responses are. But I think that in Italy, it's particularly telling is here's a commercially available robot. It looks good to me, looks professional, doesn't have that, isn't the standard black creepy robot that we've seen some coming out of some other groups. And the elderly are like, no, we're not doing it. And I think that also illustrates that we're not very good at testing and evaluation, that a lot of our HRI testing has not really focused on getting the complete demographics because it's so hard, right? You know, you don't know. Most of your studies with HRI are often with the first year psychology kids who have to sign up for something versus getting that really broad age spectrum and enough to be statistically significant.
Well, you can imagine how difficult it is when you're conducting research to extend, and there are very few longitudinal studies in HRI. So we have a lot of research that's focusing on snapshot effects rather than effects over time, which I think is a fundamental weakness. I believe so much of our response to robots is learned response, and that is something that does seem to be changing, particularly in industry, is that we're finding people are welcoming the prospect of robots far more significantly than they were 3 months ago.
Yeah, that's exciting. It's and again, since we've already had we were already at the adoption phase, moving from early to middle. It's so wonderful to see that a lot of this is going to get a big boost. And we're seeing what's really exciting to me is outside of healthcare. So healthcare has kind of been, yeah, we've been seeing it for 5 years now. We're going to really do it. But there's all these other areas. We're seeing the robots in public safety. We're also seeing robots all of a sudden get adopted for day-to-day quality of work and quality of life. Realtors are using telepresence to show houses. People are thinking of all sorts of ways of using technology to keep things going. Delivery robots, all of these things. So I think we're going to, and then of course now we're looking at a huge push on more automation of warehouses and in the supply chain. So I think it's really going to be bigger.
Yes, we're seeing a lot of growth in retail. Logistics was one of the early adopters with e-commerce pushing the trends, but retail is responding very rapidly. And I can see this segueing into the approach to manufacturing, as we've just had in terms of the local response that has happened in creating PPE, where we are going towards micro-fulfillment for retail, and that's using automation. And I think we're going towards micro-factories as well, which will be using advanced manufacturing and industrial automation and the new breed of collaborative robots, because when you're condensing factory operations into small areas, then you've got to make kind of every part of that factory smart.
Yeah, that mass customization. And there's one area that we've had, and if you go to Robotics for infectiousdiseases.org, we've got a series of interviews with public health experts that specialize in epidemiology. And one of their wish lists consistently is more laboratory automation, which isn't as sexy for us in robotics, but they're looking at the entire supply chain from when you take an infectious disease sample, you know, and how many people it takes to hand off to the lab. And they're saying that one of the big holdups in the COVID testing is there's not enough lab technicians that are trained to run the sample. So you just can't suddenly in 2 days triple that number. You can't do it in a month. But if you had more compact labs and if you had more smaller labs, then you could actually start building carts that as the person taking the sample did it, they could just start loading it in. It could start the whole process right that moment as they're wheeling down, going to the next patient. So I think there's so many exciting opportunities in so many dimensions, and everybody seems to be listening to it. And Well, the bad news is COVID is going to be for a while. So I think it's going to stay with us for long enough that it's not the usual disaster. After 2 weeks, you see that kind of tail off and drop down. I think it's going to be in everybody's memory for at least 18 months, which should help with investment.
Oh, one hopes so. So I'm really pleased that you brought up lab automation as one of the areas that is calling out for robotics automation. Out of the other gaps that you were talking about, can you highlight certain areas that you think are significant for telehealth and telemedicine where more research needs to be done?
I think there's a couple of things with telehealth and telemedicine that we're seeing that you don't get it quite from the reports, but as a roboticist, I think the biggest gap is manipulation. And Chris Hauser has a lovely series of articles. If you go to IEEE Spectrum, his work on telehealth and nurse assistants. For years in robotics, we've been thrilled silly to get to let you see and comprehend at a distance. So seeing and hearing and talking at a distance. Now it's seeing and acting at a distance. You need to pick up things. You need to hand things. You need to manipulate things. And I think that's the big gap. And of course, manipulation is extraordinarily hard. Another aspect we're seeing is the whole issue of autonomy. So telepresence, the healthcare worker, need to see and act at a distance. I want to do it. I want this robot to be my surrogate. I don't want to automate certain things. I need to be there, but I need to move. I need to do this. And we still don't have that natural and easy. The idea that we're bumping into things, that should be something, it should be, the robot should be doing. It should be like riding a horse. You don't tell a horse, hoof up, hoof down, hoof up, hoof down. You're just pointing it in the right direction, and it kind of does the right thing. And, you know, I'm a fan of Western movies, and of course the horse will go, trying to warn you that you're fixing to be attacked by bandits, you know, and that's what the type of intelligence, I think, that shared autonomy, we often get into either it's fully autonomous or you're on your own as a teleoperator. And we really need to explore that more joint cognitive type of shared autonomy.
Thank you. That's some great references there as well. Now, in your role deploying rescue robotics, you've traveled the world and you've experienced robots in incredibly harsh and difficult terrains and surroundings. One of the questions from the audience was, how are the robots that we're talking about here today, now in California, going to be viable or useful for people in the rest of the world?
Well, I think that for the COVID robots, we're seeing 21 countries are using robots. And in almost all cases, they're using them in very similar ways. Okay, so in healthcare, in particular, it seems that 7 countries are doing a lot with robots in hospitals. And it's pretty much the same categories. You're not seeing one, you know, I think in the United States, we did one on inventory, but everybody else is looking the usual suspects: disinfecting rooms, telehealth, food and prescription cards, which those in healthcare know that's been around since Joe Engelberger, right? You know, for decades on those types of applications. And so we're not seeing what we see here and what we see there. It's very global, so that's kind of neat.
Oh, that's great. Now, another question that just came up is, well, first off, can you comment on swarm intelligence and how that might be put into practice, for example, in UV disinfecting robots? Have you seen any successful examples of using swarm robots?
No, I haven't. And, you know, I hadn't really thought of it. Now, if you think of it, all of the disinfecting robots I know are working off of a one robot to room, one room paradigm. Do you get anything by having multiple robots? Well, maybe. The bigger problem, I think we know how to do distributed robots in multi-robot systems. What I think we don't know how to do is the spatial reasoning, the 3D spatial sensing and reasoning about all the spaces you would need to get to so that you would have complete coverage to the level that they're. And then I think it becomes easy. Do we need swarms? Do we need lots and lots? Do we need some up here? Do we need some here? Do we need crawling? We don't know that yet. And every room's going to be a little different. I mean, one of the things with the hospital robots, the UVC disinfection robots, is they're great for hospital rooms because there's not a lot in them. They don't work as well for ambulances. They don't work as well for very cluttered areas, waiting areas, break rooms, because there's a lot more surfaces, a lot more stuff, a lot more clutter. Could they work? Yeah, but putting them in the middle is not going to work for those types of spaces. Can we sense that? Well, we've got a planar laser. We have this. Well, how do we make this cheap, easy, fast? You know, so I think that's the holdup, not the swarm. I think that's the easy part. I think it's the spatial comprehension.
Well, thank you. That's a really great answer. And it was a very fantastic question. Thank you, Justin. And I think I have time for one more question. You've just written an article on science fiction and robotics. Is that correct?
Yes, pandemics, looking at what science fiction has to say about that.
Oh, that's fantastic. And where do we find that?
That's you can find it on Science Robotics, and if you don't have a subscription, you can get behind the paywall by going to robotsthroughsciencefiction.com. That's my website and blog.
Oh, wonderful. I'll make sure that that's into the chat because I'm definitely looking forward to that. So just to do a little bit of a recap, you identified gaps in lack of appropriate autonomy, not meeting health and safety standards, and being unable to prove reliability. And that's actually something that comes up for any sort of robot. It's not the thing that you think about when you're first designing robots, trying to save the world, but it's exactly what prevents you from deploying into various places. And you identified poor human-robot interaction, you know, lack of adaptability and flexibility there. And I think you've also now pointed out lack of lab automation is a really major area that we should be focusing on doing more in robotics, and solving the spatial analysis and spatial reasoning is a fundamental thing that we need to do to move robotics forward. Is that I think that's a reasonably good recap, but I'm just thinking, you know, on other talks that I've had with you, you've also mentioned very strongly that roboticists need to go to talk to experts before they plan to put a robot into a field.
Well, absolutely, Andra. And I think that's what the data is showing. If you look at that idea of the heritage, the engineering, and the new, there's really very, very little new robots being there. And each one of those was already in a partnership with healthcare experts. So it wasn't like they just suddenly woke up one day and were granted access to the hospital and they were suddenly doing this. And no, they were already working on the regulations and the IRB approval and everything that you need to know. And certainly the biggest category of use was heritage. 25 out of the 36 already were commercially available. Then the next 8, they were modifications, minor modifications of existing commercially available. So it's not like, you know, if you're going to do this, you in the engineering cases there too, they were in partnership with the hospitals. So being roboticists, we're very good at being roboticists, but we're not very good at other people's domains. So we need to have our partnerships and reach out to the medical profession. And as one of the program leaders here at Texas A&M with Houston Methodist said, yeah, we need to put on our engineering hat, not our research scientist hat. This isn't about pet projects. It's about going to them and saying, what's your problems? And then looking at that list and seeing if there's a problem that we can attack and solve and do a good job with.
That's fantastic. You've just actually answered Alar's question, really. How do robotics researchers deal with the current shutdowns and limitations in many ways, and the best practices to solve that? And I believe that's what you have just answered, and that ties back to the interviews that you talked about on the Robotics for Infectious Disease site, where you've already interviewed people at the front, at the leading edge of healthcare, to talk about how to work with them and what problems they have and what problems to solve. So, you know, thank you very much for being ahead of this whole COVID crisis and helping us develop the right robotics to solve the world's problems. Thank you. Thank you very much, Robin. This is when we all applaud. Okay.
Thank you all. I hope it's useful to you.